Greetings to you from India. I'm Dr. Ajay Shetty, a spine surgeon from Ganga Hospital, Coimbatore. I'm going to speak of something that is relatively rare and of interest mainly to both pelvic surgeon and also for the spine surgeon. The topic today is spinopelvic dissociation. Before I go into the topic per se, I will give a brief outline about the pelvis anatomy. As we know that the pelvis has got an anterior pelvic ring and the posterior pelvic ring. The anterior pelvic ring amounts to about 30% of the pelvic stability, and it is made up by pubic symphysis, the bilateral pubic rami, and the ventral ilium. Whereas the posterior pelvic ring amounts to about 70% of the stability of the pelvic ring. It contains the dorsal ilium, the sacroiliac joint, and the sacrum. The pelvic fracture is a high energy trauma most of the time, especially following a road accident. There's a disruption of anterior and the posterior osteoligamentous structures, can cause vertical or rotational instability. It could be associated with other injuries of the other organ system, could be a part of a polytrauma, and there could be a lot of soft tissue compromise. Therefore, the aim of treatment of these fractures is to early restoration of the structural integrity of the pelvic ring, to normalize the physiology and early return of mobility and function. There are various fixation methods. The anterior pelvic ring could be fixed by external fixation, ORIF, transosseous intraosseous screw fixation, and the infix, and the posterior pelvic ring by the iliosacral screw and the anterior sacroiliac joint plating, most commonly. This is few case examples of fixation. And now, apart from the symphysis pubis, most of the pelvic fractures can be fixed percutaneously if you are able to achieve the reduction by closed means. Infix is one innovative technique introduced by Professor Rahul Vaidya, which basically stabilizes the anterior pelvic ring, especially fractures involving the pubic rami. Sorry. I would like to talk about one more aspect of the pelvic ring injury, what is called as the spinopelvic dissociation. The spinopelvic dissociation is also called as spondylopelvic dissociation, is a spectrum of highly complex atypical sacral fractures. It causes multiplanar instability and involves the lumbosacral junction. The sacral fractures are basically bilateral, vertical, and transverse fracture components, which basically separates the lower lumbar spine from the pelvis. It was first described by Roy Kemel in 1985, and he noticed it following a suicidal jump, and he called it a suicidal jumper's fracture. As you can see in this fracture, basically is a U-shaped sacral fracture, and there is a vertical component and a horizontal component, making it a U-shaped fracture. This part, the center part of the sacrum, is attached to the lumbosacral spine, whereas the outer part of the sacrum is still attached to the pelvis. And therefore, there is a dissociation of the central part of the sacrum with the spine and from the outer part of the sacrum with the pelvis. And this is what is called as a spinopelvic or a spondylopelvic dissociation. And this, as I mentioned, is a classical H&U type of fractures, causing a lumbosacral instability, first described by Roy Kemel. This has always been a no man's land. I mean, either it is managed by a pelvic surgeon or managed by a spine surgeon. But I think it's more important to understand that it needs the skill of both the pelvic and a spine surgeon to address these injuries properly. Because about 40% of these injuries also will have involvement of the pelvic, other components of the pelvis. Coming to the biomechanics, the sacrum is an inverted wedge-shaped amalgamation of the 5 fused vertebrae. The sacrum forms the caudal base of the erectus or spinous column, acting as a keystone. And LS motion segment is the cornerstone of the lumbosacral stability. The lumbosacral junction is a transitional zone between the lumbar spine and the posterior pelvic ring, and includes the lumbosacral motion segment, the sacrum, and the ligamentous complex. As you can see, the stability of the lumbosacral junction is provided by dense soft tissue restraints. The capsules, the ligaments, the iliolumbar ligaments, they all provide stability. And For instability to happen at this junction, it's not only the bony component or the capsular component, it also the ligamentous component that needs to be injured. The mechanism of these type of injuries is a high velocity injury, could be a polytrauma, suicidal jumps, road traffic accidents, and a bomb blast. What is the mechanism why you get this U shape of fracture? Usually when you have a suicidal jump or a fall from a height, is a high energy axial load. There is a bilateral vertical components causing a vertical instability. And then the central component pivots into flexion or extension with a transverse fracture line between S1 and S2. Therefore, the upper sacral segments to remain attached to the spine and the lower sacral segment to remain attached to the pelvis. Why it is much more important is the fact is that whenever there is a kyphotic angulation of this fracture fragment, there is an increase in the sacral slope and the PI, and leading to a mismatch of the PI and LL, leading to sagittal imbalance, which is based on the kyphosis. And this is very important. Therefore, this angulation has to be corrected to get a good clinical outcome. Coming to the classification, we know about the standard Dennis classification of sacral fractures, type zone 1, zone 2, and the zone 3. Whereas the zone 3 one is medial to the canal, is the central one, higher chances of neurological deficit and can cause a lumbosacral instability. We also know about the isthmus classification of the lumbosacral junction. Type B and C, that is the fracture going through the facet joint and medial to the facet joint, they are the one which denotes a lumbosacral instability. But the most important classification when compared to this type of dissociation is probably brought about by Rock-Camel with the morphological classification of the U and H type and the T and the Y type of fractures. And with the angular displacement, type 1 is there is a kyphosis, but there is no displacement. Type 2, angulation with anterior displacement. Type 3, posterior displacement. And type 4 is a segmental combination of the S1 vertebral body. This is well depicted by the Harborview Radiology Department with a combination of both the coronal and the sagittal cut of these transverse sacral fractures. In the EVO classification, these fractures comes under the type C1, C2 type of fractures. But I would recommend to all of you to read this very interesting 2 articles came out by the 4 experts in spinal trauma, especially the spinopelvic trauma, who have described a new term called as traumatic lumbosacral instability. It is basically the disruption of the structural integrity of the lumbopelvic junction, which causes a separation of the spinal column from the pelvis at the level of the lumbopelvic junction. They classified 4 types. Type 1 is a lumbosacral dissociation injuries. Type 2 is a spinopelvic dissociation, which I'm going to talk about. Type 3 is unilateral vertical sacral fracture with ipsilateral L5S1 facet involvement. And type 4, that is basically almost similar to what the type B classification. And type 4 is basically bilateral vertical sacral fracture without a transverse fracture component. And there are 2 articles in the same journal, one describing the proposed definition and identifying the injury pattern, and second, defining the indication and techniques for surgical management. It's just published this year. It's a very interesting article. I would like to give credit to all the 4 authors to coming out on something which is rare and very, very well explained article. The clinical presentation and diagnosis is a bimodal distribution. Young individuals, usually what we see about high energy trauma. Elderly is probably osteoporotic, the fragility fractures. But what are the important features of this? The important features of all of this spinopelvic dissociation and all the other lumbosacral instability is the fact it's relatively rare, even in busy centers. Ours is one of the busiest trauma centers in the country. And even then, the amount of these traumas, what we see is relatively rare, number one. It needs an amalgamation or a combination of spine and pelvic surgeons to operate together. There is always associated injuries to the other structures, head injuries, chest injuries. Actually, 40% of them will have associated other injuries to the anterior ring of the pelvis. There is extensive soft tissue injuries which can happen in the form of a moral level lesion. and which makes your access or approach or open procedures much more difficult. And about 40 to 50% of this patient with spinopelvic injuries have got a neurological injury, which is usually missed, affects the bladder and bowel function. Always look, and especially if there's a suicidal jump, they can have a bilateral calcaneum fracture and they will be in a slab. Therefore, it's important for us to look for toe movements, identify whether the L5 and S1 roots are most commonly functioning well, do a rectal examination, evaluate the sphincter toe and perineal sensation, and also look for perineal lacerations. Therefore, it's very, very important to identify these type of injuries and identify the associated injuries which can happen in this group of patients. Plain radiographs, even though we take a AP, inlet, outlet, and the lateral views, this can be easily missed. Therefore, in the AP pelvis, a paradoxical inlet view or irregularity of the sacral foramen can give a clue. A lateral view, the angulation or translation, if it is seen well, can give us an idea. Look for a vertical translation or a L5 transverse process fracture, which is also an important clue. CT scan is very, very important with reconstruction. But it's always important that in your center, the CT scan should include L4, L5 vertebra, lumbar vertebra, along with the hip joint completely, or below the part of the upper part of the femur, as you show depicted in the figure on the right, so that you won't miss transverse process fracture. We know that the iliolumbar ligament are attached to the transverse process, and a transverse process fracture indicate there's some sort of instability at the lumbosacral junction. It's important to go through the CT scan with reformation, as I see here, a classical example of a spinopelvic dissociation. MRI is useful mainly in osteoporotic fractures to see the osteoporotic type of sacral insufficiency fractures. Coming to the management, non-operative management are meant mainly for low energy insufficiency fractures. In traumatic spinopelvic dissociation, they are inherently unstable. But however, in low resource settings, when the patient has got a poor general condition, or the associated injuries make it difficult to mobilize the patient, that you probably will need 1 to 2 months for him to mobilize. If there is not a displaced fractures, probably you can treat it by conservatively. When the neurological condition is okay, strict bed rest with or without femoral traction, delay the weight bearing, probably could have a role, especially when the patient is not affordable, undisplaced fracture, and other injuries make it impossible for him to be mobilized early. If there is a definitive treatment, especially patients if they've got an anterior pelvic ring, I would always prefer to fix the anterior ring first, because it achieves an excellent indirect reduction of the posterior column, posterior ring, and better in patients with polytrauma. Because as I mentioned, about 30 to 40% of them can have associated anterior ring fractures. What are the surgical goals? Achieve a stable fixation, restore the pelvic anatomy, decompress the neural elements, and to mobilize him as early as possible. Understand these injuries are spinopelvic disruptions, and therefore you need to fix the pelvis by iliosacral screws. You need to fix the spinopelvic junction through a spinopelvic instrumentations. When do you do the treatment? Usually as early as possible, within a week. If there is a vertically unstable component to the fracture, apply distal femoral traction. Delay, because it's a cancellous bone, early callus makes a reduction very difficult. Close reduction usually works well if you do within 72 hours or probably up to 1 week time. There are many ways to do it. Supine was described by Roche et al. I have tried this. It works quite well if you are able to do it within 2 or 3 days time. The patient is positioned supine with true supracondylar stimulant pins being applied on both legs. As you can see, there is a hyperextension of the lumbar region by multiple pads kept underneath, and give continuous traction and a counter traction by somebody holding the head or the shoulder. Give continuous traction. You suddenly will hear a sound and then it reduces. And then you fix with the iliosacral screw. But it's also important, what would prefer is to turn him over after that and do a spinopelvic fixations. Prone technique was advised by Williams. On a specialized table, you can give traction, counter traction with the counter traction. being applied by the Mayfield tongs. The knee is flexed, and then you give traction. You can extend the knee also to reduce the kyphosis. What I would usually prefer is this technique, which is well depicted in this picture. Patient is made to lie down prone. The knee is flexed to 90 degrees. You hyperextend the hip. At the same time, press over the sacrum where it is angulated. Usually, you tend to get the reduction if you have been operating within a week's time. If you are not able to get it, then the open reduction, wherein you put a distraction between the spine and pelvis. It's basically a traction, like a ligamentotaxis. You put a shank pin or screw at L4, another shank pin or screw into the ilium. You distract it. Usually, it helps to correct the kyphosis by the distraction methods. Or you can also use by joystick maneuver. Once you have achieved your reduction, what are the options of fixation? The spinopelvic fixation is mandatory. It's a powerful internal fixation method with L4 and L5 pedicle screws, along with the pelvic fixation. The injured hemipelvis is connected directly to the axial skeleton, bypassing the fracture zone. The vertical displacement of the hemipelvis is resisted, and the rotational movement would be resisted if you are putting a sacroiliac screws or iliosacral screws. The combination along with sacroiliac screws is what is called as a triangular osteosynthesis, and biomechanically is the strongest. We have to remember spinopelvic fixation is a very powerful internal fixation method, wherein the L4-5 pedicle screws and the pelvic fixation is performed, and bypassing the injured zone, and the hemipelvis is connected directly to the axial skeleton. It resists vertical displacement of the hemipelvis. The combination of the SI screw is called as triangular osteosynthesis, and biomechanically is very, very strongest. We have to remember that we have to achieve good reduction before we can put iliosacral screws. A brief word about spinopelvic fixation in trauma. The indications could be spinal trauma at the lumbosacral junction, but we have to remember in pelvic trauma also there is a role in comminuted sacral fractures, lumbosacral dysmorphism, and spinopelvic dissociation. We always need a carbon fiber top table. I mean, it may not be applicable to in the developed nations, but in low resource settings, we should remember that we need a carbon fiber top table to perform this, because a regular steel top table will prevent you from seeing a good inlet, outlet, and the teardrop view, which is very, very important. An obturator oblique outlet view. You can see the teardrop here, and this teardrop is a channel which runs from the posterior inferior iliac spine to the anterior inferior iliac spine. Therefore, through this part, you are putting the iliac part of the iliac screw fixations. There are many ways to do it. You can utilize a midline approach. You can utilize a percutaneous approach. I prefer to use a Wilsey approach, a paraspinal approach, and incision which is centered over the transverse process. This is a different case. Otherwise, I would always prefer to do bilateral fixation in spinopelvic dissociation. It makes it easier, much faster, less radiation for you, and good wound healing with less issues. As I mentioned, the iliac screw could be done by the classical method, or it could be subcrestal so that it becomes less prominent, or it could be S2 AI screws. These are the intraoperative C-arm pictures to know that you have positioned your screws quite well. Therefore, the surgical methods could be percutaneous, closed reduction, indirect decompression and fixation, or open reduction, decompression and fixation. It depends. The percutaneous fixation could be ideal for a relatively undisplaced fractures, or you are able to achieve reduction. Closed reduction and indirect decompression and fixation either by open and percutaneous methods. Open reduction, especially when it's a bit delayed and you're not able to achieve closed reduction. And when you want to fuse, it would be a better option. As I mentioned, optimal is a triangular fixation. A spinopelvic bilateral is preferred with iliosacral or even the transsacral screws when the sacrum is significantly comminuted. The decompression usually is indirect if you are able to achieve the correction of the kyphotic deformity. But however, you may need to do an open reduction, especially in situations where you are not able to achieve a closed reduction, or when the patient presents late, when you are not able to achieve it even by an open method. You may have to do a wide decompression, but you have to beware that there is a higher chances of traumatic dural tear. Fortunately, there is no statistical difference in neurological outcome following laminectomy versus indirect decompression. Let me share you some of the case examples of mine wherein we are fixed by the spinopelvic stabilization in a transitional vertebral anatomy. And in these scenarios, I would prefer to go from L4 to the ilium rather than going only from L5 to S1. I usually do not advise implant removal, but however, sometimes when the implant become prominent and the patient are not comfortable, especially in a situation, we tend to advise implant removal. One more example of a spinopelvic dissociation reduced well by indirect methods and a good clinical outcome and a radiological outcome. But ideally, as I mentioned, a hybrid fixation with a triangular fixation would be the most ideal thing. And when you're not able to reduce, if they present late, at least an attempt should be made for an indirect decompression or a open reduction methods. One more example of a percutaneous fixation with a good outcome. Either you can do it open, paraspinal is what we usually prefer, and this is a MIS technique with a good clinical outcome. Therefore, when to go to L4? When you have a transverse process fracture of the L5, comminuted sacral fractures, you are unable to insert iliosacral screws, then it's always safer to go up to L4. And if there is a gross instability, you're not very comfortable with one screw, there's no harm in going up to L4. The current trend, as I mentioned, is to use minimally invasive technique, probably ideal when you are able to achieve a reduction, and especially when the patient presents to us quite early. We always remember that an anterior ring fixation is always necessary to make the patient mobilize. Prognosis, there is a reasonably good chances of neurological recovery. About 50 to 60% of them do recover in terms of neurology and the bladder bowel functions. Only the transaction was found to be the cause of a permanent deficit. Implant failures does happen, especially if there is a vertical component which is significantly displaced initially, mostly silent, and reason may be lack of the fusion that happens. Prognosis-wise, most of them do well. About 80% of them return back to work with a significant improvement in terms of pain. And this is what is important. Try to recreate this angle so that there is no disturbance to the PI, which will in turn affect the lumbar lordosis because there will be a mismatch of the PI to lumbar lordosis, causing a sagittal imbalance and causing a poor outcome. To conclude, spinopelvic dissociation is a highly complex pattern, involves the sacrum, resulting in a multiplanar instability of the lumbopelvis, bilateral vertical sacral fractures with a horizontal component. It is a part of a lumbosacral instability syndrome, and one of the important components of it. The CT scan is very, very important for the diagnosis. The preferred option is a triangular osteosynthesis, which includes a spinopelvic fixation with the iliosacral screw. I thank you all for this opportunity and hope to see you all in person. Thank you.